have some idea of it too. So let's get into it a little bit. I want to talk about the DSM and what anxiety disorders actually are. I'm going to go through some of the language and some of what you need to know. This is my electronic DSM that is kind of helpful to kind of go through a little bit. And then we're going to go through some of the PowerPoints on it as well and some things. Let's actually go to the slides first. So looking at changes in a little bit from anxiety disorders. Now, the prevalence of anxiety disorders is significant. This is a handout from your Blackboard shell, so I'm not going through anything you guys don't have copies of. And so anxiety disorders, lifetime prevalence about 30%. The anxiety disorders are a significant portion of what you will see working in this field. Between anxiety and depression, I'm going to estimate that's going to be roughly 70% of what you see. These are the most significant and major issues that come up across all spectrums of what you're going to be dealing with. So you're going to want to be able to learn how to manage those things and learn how to kind of get a feel for them. And so you have a knowledge of them. 50% of individuals that were treated for anxiety disorder also met criteria for depressive disorder. This is pretty significant because what you're going to find is people don't know their diagnosis. You're going to want to trust them to come in and say, I feel depressed. Oh, okay, we're dealing with depression. I had one this week that came in just set on depression, and was really suffering from an anxiety. And then I've had another one this week that came in with anxiety issues that really was Asperger's. So people will often come in and what they're presenting with and what's popping above their radar, they've interpreted in certain ways. So it's very common if somebody has an anxiety disorder, struggle with anxiety, look for the depression. You're going to find those comorbidities in a lot of different things that we deal with. I've never met anybody that has chronic pain that does not suffer from depression. Never met that person. So just have that understanding that, I mean, when people have those types of things going on, you're going to see some comorbidities that are common. Anxiety. Now, does the anxiety cause the depression, or are they so worried that they feel a lack of confidence and they actually have the depression? Some people do. Some people have straight anxiety. Some people have anxiety with some depression. Some people have depression with some anxiety. Again, you're going to look at your diagnosis coming from what's really kind of popping up above the radar the most for them. And so there are some changes to the DSM in DSM-5. And so just some changes in things. Selective mutism, selective separation anxiety disorder. Some changes for social phobia to social anxiety disorder. So they've combined some different things and made some different groupings a little different in the names. It removed panic attacks as a specifier for agoraphobia. Does anybody know what agoraphobia is? Yes?
Fear of going outside.
Right. And that can be fear of anything. So let's say somebody has a panic disorder and they fear then going out. Let's say somebody's been in a really traumatic car accident. Had a client once was driving down a highway in our area in a Suburban, baby in the back seat. Somebody on the other lane of traffic going 55 miles an hour had a medical event occur, went unconscious. The Ford F-150 slowly crossed the median. She saw it crossing the median. She swerved to avoid it, hit the back side of the Suburban where her baby was, grandbaby. The Suburban was totaled. Baby was okay, and grandma was okay. Grandma did not want to get back in the car, ever. Panic, a lot of anxiety, felt like she would be safest if she never left the house again. So that was kind of the dynamic. So the not wanting to leave the house again is the agoraphobia. So agoraphobia often comes from that. You're going to see it most prevalently when you deal with people who have panic disorder or panic attacks of any kind. Because if you've ever had a panic attack, or if you ever know anybody, they have a panic attack and then they think, what if this happens when I'm at school? Or what if it happens when I'm going to pick my friend's house or going to that party tonight? So what they do instead is they then will avoid those things for fear that a panic attack will occur. And so those are things you start to run into a little bit and have some problems with, because you begin to see panic kind of setting in, and then whether they have another panic attack or not, we don't know. Now they have anxiety about panic attacks, and that's causing them to be afraid to actually leave the house or do any kind of stuff like that. So does anybody know what a good treatment modality is then for people with agoraphobia? Yeah.
Just a thought, like a fear hierarchy or desensitization.
Yeah, desensitization is a really good one. What a lot of people like, though, that have panic attack disorders or panic disorders is video-based counseling. So a lot of times video-based counseling is very good with, it also works very, very well. A lot of evidence, a lot of research on people who have disorders of self-esteem. So if they have any kind of eating disorders and things, sometimes video works really well for them as well. But anyways, yeah, absolutely, desensitization is a really good treatment modality for trying to deal with some kind of panic and agoraphobia. Differential diagnoses, we talked about that last time, the differential diagnosis of anxiety disorders and depressive disorders. Again, what's comorbid? What comes with it? What else should you be looking for? Our big thing. So depressive disorders are sometimes viewed as anxious misery. Again, anxiety disorders are often included as anxious anticipation of uncertainty. So you're likely to see sleep disturbance. You're also likely to see cannabis use or other substances that are alcohol abuse. People often try to self-medicate before they come see you. So they've often tried a lot of different things. I had a client that swore by nerve tonic. You ever heard of nerve tonic? Nerve tonic, yeah. So that it was just an amazing thing. We had a bottle pop up at our house, not a nerve tonic. I don't know what that is, but they swore by nerve tonic. And but my wife was like, "Oh yeah, this is." She met her good friend who's in. They do a lot of. Well, they don't do. They're kind of like into this, a lot of herbal things, and she was like, "This one's supposed to be really calming." And he can't even pronounce the word on the bottle, but apparently there's some pill that's all brown looking that you're supposed to take, and it's calming. So there's all this stuff that's like people will package in ways to try to help out, and sometimes things work, sometimes things don't work. I had a patient recently just say, "Look, I'm gonna go back. I'm gonna try CBD oil. Let's try cannabis oil to try to see if that's gonna help affect the anxiety and those type of things." So those can kind of have some issues too. Separation anxiety was moved to disorders childhood, age of early onset too. So separation anxiety we'll get into later a little bit. Selective mutism is the voluntary refusal to speak. So people who just refuse to speak, you'll see that happen every once in a while, mostly with children who will just not want to speak. And they have the capability to, they just refuse to do it. You may find kids who experience trauma will go through some of that and have some of that as well. Specific phobias are just what they say. They're phobias of something very, very specific. So when you see anxiety, you're going to look for this as well. You're going to want to know if there is in fact, a specific phobia that maybe it is. So, because it's a lot easier to treat it when you start treating anxiety disorders, which I'll get into in a minute. You're going to start unpacking what factors surround that are really influencing the anxiety. So some of us call them triggers. What are some of the triggers of anxiety? Some people have panic, and there are no triggers. They just panic. And so I'm going to get into why that is in a minute, which is kind of critical. But yeah, specific phobias can come after a traumatic event, witnessing an event, something that occurs. They may have something happen, and then they are no longer want to be associated with that type of event. Typically around 13 is when they start coming on. You could have a panic attack with them as well. All kinds of different specific phobias. Because remember, if it's a specific phobia, you want to narrow it down as close as you can when you're doing a diagnosis. You don't want to just leave it as generalized anxiety disorder when there is, it only happens around certain triggers, you know, because then it's not generalized. But if somebody has been their entire life, ever since I was a kid, I've been worried about everything. And I remember my mom, you know, I remember I put something away and I saw something on the floor and I started crying, and my mom, you know, I thought, you know, it just kind of going, this whole history of being anxious. That's going to be generalized, and where if they have something specific happen, it'll be a little bit different. Or if they're transitioning to something and they're coming to grad school for the first time, they haven't been to school for 20 years, going back to get their master's, but they don't know if they can do it, and they're panicking and they're upset, what is that going to be leaning toward? Adjustment disorder with anxious mood, or with anxiety, depression, or mixed, or unspecified. So yeah, you're going to go with that adjustment because there is a precipitating event, there is an adjustment to something that's coming in that's causing the anxiety, that narrows down what the cause of the anxiety is. So the more information we can get in that, the better, to kind of get them to have that general feel and stuff too. Social anxiety disorder, called SAD. Originally classified, has been named a little bit differently now, but again, you got it's very much socially driven. You're going to find people who just don't want to go to big events. They don't mind going to small events, but don't want to go to large events. You know, those type of things where they have. I had a client that had social. I had several, but one of them really wanted to go to a concert in Charlotte. I forget who he wanted to see. Anyways, he wanted to go to this concert in Charlotte, but was really afraid of going to public places. He wouldn't go to. He was a college student locally. He wouldn't go to parties. If he went to parties, he'd just sit in the back room freaking out. So he had a lot of social anxiety and panic, and it took us about 6 weeks. And he was fine going to parties, fine going out there, and he just was fine. So it doesn't take a lot of time with the protocol that I use to get some kind of stuff, which I'm gonna give you all that today, so you have it. But generally, that's the big difference there. So often in conjunction with major depressive disorder, other anxiety disorders, or substance use disorders. Again, the substance use for treatment, you know, and then you have the major depressive, because you can imagine if you're not going to you don't feel like you can go to any events, all your friends are going to, that guy you really want to hang out with is going there, but you just can't. I mean, that starts getting to a place where you're starting to feel depressed and sad and questioning whether you'll be alone the rest of your, I mean, all that kind of starts spinning and can create this narrative of depression. And so I say narrative because it's more of a CBT term, you know, where cognitively you're going to look at the way someone processes something to really kind of create a different way of looking at it, which is called reframing. So reframing works really good with a lot of those types of things. And but again, I often put that, not to steal from narrative therapy, which is fine, but I use the word creating a narrative often. I use a phrase with clients a lot, but you've created a fictitious narrative. So that challenges their whole paradigm of looking at something. So you consider all these parties and things, and you've created a fictitious narrative in your mind of what's going to happen. And so it's my way of giving them control, and my way of telling them that they've created the thought and that it's fiction. It's not based on any data. So that's a way I can communicate 3 thoughts to them pretty efficiently. And then we go into more of a let's create a more realistic narrative. You know, so we know. So yeah, social anxiety can be performance as well. So a lot of performers, a lot of musicians, professional musicians use propranolol. If you've ever heard of it or not, it's a medication. It's a blood pressure medication that came out. And what it basically does is it has a side effect that is common for like 30, 40 minutes. So for public speaking, for students giving speeches and stuff, it's a really common drug that's prescribed to just help in those situations. Because that's a situational if you can't, just whenever you give a speech, you freak out. There's a medication that can help you give speeches calmly, and that's what it does. So very, very common. Students use it a lot. Like I said, a lot of different doctors use it. But if you need something for those type of things.
It's called propranolol?
Propranolol, yeah.
Or propranolol?
I think it's propranolol.
Panolol.
Panolol? Oh, thank you. Panolol. Yeah, thank you. But again, SSRIs, we'll talk about how the medication works too tonight, just give you some idea. But so panic disorder is a recurrent, unexpected attacks. Again, initially it was a DSM-3, but median age of onset is 20 to 24 typically. Some experience panic earlier too, usually a little bit older when they start having panic attacks. Not usually seen first over the age of 45. Generally, by the time they hit 45, they're not. If they have it, they have it. If they don't, they don't. Rates of prevalence 2.1 to 2.8, and we have one of the highest rates in the nation, in the world rather, in America. Panic disorders. You start getting into some of that a little bit too, where persistent concern of inappropriate fear responses. These are all coming under the anxiety disorder umbrella as well. Physical symptoms, cognitive symptoms, and remember, you're going to see different symptoms in children. So if you're assessing children, you're going to see different symptoms, and those are all delineated in the DSM-5. You'll see different symptoms for children than you will see for adults. Like children who have depression might be angry. You might see an anger or acting out behavior. You may see even aggression, where it's more depressed. So instead of just going, well, that's just they're just angry, they may be depressed from that too. So same thing with elderly. You'll see some different things with different features too. So again, panic disorder is common in a lot of physical. You're going to notice this a lot with the physical. So you can't separate the mind from the body, like we talked about. So the body's going to respond to panic. And a lot of it we talked about already. A lot of it's right here in the middle. So like stomach pains, we talked about this already. Really hard to diagnose medical conditions because there's so many emotional conditions that that come in that area and affect the body. And so, but just keep this in your mind though. Illness, anxiety disorder used to be hypochondriasis. Hypochondriasis is very common. That people they really have this fear and anxiety over a specific illness. They may think they have it or they may fear having it, but you kind of can see the difference a little bit. But there's a lot of that as well. So panic attack specifiers don't have specific codes. Let me see, we go. Agoraphobia we kind of got into already. Wide range of situations. Agoraphobia lends to moderate to severe impairment in function with over 33% of people diagnosed. That's probably very accurate. Over a third have severe impairment, like can't go outside, can't go anywhere, those type of things, significant problems. You could imagine with the client I told you about, the Suburban, it took 6 weeks to get her in the office because she had to do what to get in the office? She had to get a car. So, big difference. I see a parent of a child that was in CHKD with a very, very serious illness. The child is in recovery from the illness. Parent does not live in Norfolk. My office is in Norfolk. And so I've told the parent saying, I want to come in and see you to talk about, everything that's gone on and work through some of this anxiety I'm having. So obviously I'm using to my advantage the fact that my office is in Norfolk. Because she said, I put off coming to see you because I don't want her to come back to Norfolk. Can we meet someplace else? And I want her to come to Norfolk for treatment because I want her to be elevated when she comes in the room. I want her to already be feeling, and we can work very quickly because she's actually experiencing the symptoms in the room. And so that can make a big difference over it as well, with treatment as well. So it's an advantage that she kind of has here too. So generalized anxiety disorder, one of the most common, excessive worry about a number of events. So for GAD, what you're looking for is multiple domains. So if you just have anxiety when you walk in this classroom, and the rest of the time you walk out, you do not have anxiety. You do not have generalized anxiety disorder. You have a specific phobia maybe, or you have anxiety that's very situational related. So you wouldn't meet the criteria for that. So what you're looking for is that excessive worry about events. And they're just people who tend to worry, and they worry a lot about different things. But it is more of a catch-all because it's broad. It's a real broad brush anxiety, everything anxiety related. And so essential features of anxiety: restlessness, feeling keen on edge, being easily fatigued, difficulty concentrating, irritability, muscle tension, sleep disturbance. Those are good diagnoses, kind of look for different criteria. Keep in mind, a lot of things have those. Depression has almost the exact same list. So people suffer from depression and anxiety. The same parts of the brain are active. They have the same symptoms. We've already talked about this with borderline personality disorder and bipolar disorder. It's the same parts of the brain that are acting certain ways. So you see a little bit of similar behavior between the two, even though they're very different in what they came from. So again, OCD, post-traumatic stress, adjustment disorders, you know, there's a lot of them out there we're going to look at here in a minute, but give you some idea there. Yeah.
So with generalized anxiety, you said there's often similarity to depression. How would you identify whether it's one or the other?
Well, it could also be ADHD. There can be adult ADHD. People are frustrated. So let's say they came in. So I always think of it like a meal. Okay, like you know, like
so it could
do you want a plate of fries with a side of hamburger? No, you're gonna get a burger with a side of fries, or a burger. You know. So what's really out front? What's predominant in what you're seeing? And so you may see, okay, there's a depressive feature. Now, when you start unpeeling it, not consider like an onion. Unpeel the onion and start looking around. Somebody comes in, they say, I'm really struggling, I feel sad, I keep crying, and you're depressed. You met with them in 15 seconds and you have the diagnosis. So that's when you kind of keep unpeeling the onion. You see what's kind of going on. You find out they have, you know, complex grief, or they're struggling from some other kind of loss. You know, you may find out more about the story that gives you a more clear, you know, diagnosis. So you want to look for all these things. So if they come in for something like anxiety, but then you start thinking, okay, they're really not, they're profoundly down and depressed. You know, you may give them the Beck Depressive Inventory or something like that, and they score like a 23. And you're like, whoa, that's loss of pleasure and this, I mean, they're also, so in their mind, the anxiety is screaming. They don't see the depression, but they show depressive features when they come in. That's why you'll often find those guys that come in and they're like hyper controlling, and they don't think they're angry, right? They're like, you know, I'm not angry. My wife told me to come here with anger. I got no anger. She's always thinking something's wrong with somebody. Now something's wrong with me, and today I'm the one, and I'm not, you know. And he's like, doesn't recognize anger whatsoever. And so it's real common to kind of have that, you know, that what he's coming in with is one thing, you know, or what he thinks he's coming in with, but what do you actually see? So you want to dig deeper than what people tell you. So yeah, you're going to see that, but you want to look for the depression that's in there as well. And so a lot of times they come together, so you're going to look for both of them. You know, and I'm also in the intake going to be asking then, what do you about alcohol? I'm going to be looking at those type of things as well. A lot of people drink alcohol to sleep better. They drink alcohol to adjust for, you know, depression, or they do some other drugs to try to take away, you know, feeling or whatever. You know, so you're going to kind of, you know, try to figure that out a little bit. So you're going to look for what's the most obvious, what's the presenting problem. Remember, we're triaging. You know, so if they said I have a panic attack this morning, you know, we're going to deal with that. What we want to stay away from is our own interests. We may have specialties and interests that pop up that we don't want to, you know, that we want to deal with. So one of mine is anxiety disorders. Sometimes people come in and they don't have anxiety, and they said they came in for anxiety, and I'm like, man, I really was thinking this would have been more anxiety. This is really more of this. But I catch myself like almost not disappointed, but almost like I had a smoking gun solution to this problem, and this one's a little more complicated now. This is more complicated than I thought it would be. So sometimes that happens. And it's good to have that general thing, because once you start unpeeling things, things come up. You can find a lot of different things that go on. Now, when I say a lot of different things, I'm describing all this, you're going to look at beyond just the negative. You're going to look at positive. What strengths do they have? What coping strategies are working? And all these type of things. So you have a general idea of what works for them. I used to be depressed, so I do a ton of scaling. So if somebody comes in and they're like, I was feeling down. I've been feeling really depressed, and okay, when's the last time I had a suicidal thought? 2 weeks ago. Okay, what was the thought 2 weeks ago? 2 weeks ago, I was just thinking, nobody cares if I'm here. I could just die. Do you have a plan? No, I don't have a plan. Okay, so you're feeling that low. How low? A scaling from 0 feeling wonderful and normal, and 10 being the worst you've ever felt in your life. What were you 2 weeks ago? No, say I was an 8. Okay, so what are you right now? I'm like a 5. Okay, so now you're a 5, you were an 8 2 weeks ago. When were you at 10? And they're like, oh, I was at 10 when I was 16 years old. I actually attempted suicide. I was in a hospital for a while, and then So what helped you feel better when you got out of that hospital? So now what am I looking for?
Strengths.
Yeah, I'm looking for their strengths. I'm looking for coping strategies they already understand.
Yeah.
Because I can migrate that for them easier than I can teach them a new one. So instead of me taking a coping strategy that I like and try it, see if it works for a couple weeks, I'm taking one they already know, and I'm going to teach them how to apply it to this part of their life. Now sometimes it's challenging. Sometimes they're like, well, my friends around me really helped me, but now I'm new to this town and I don't know anybody. Okay, so now we know they probably have normal stressors, but they don't have the protective factors anymore, right? They're not maybe more depressed than they've ever been. They just don't have the strengths that they used to lean on. You can always tell when somebody has a coping strategy, whether it's healthy or not. You can always tell it's a coping strategy by how they respond to it. So I had a patient recently, had a child, going through some stuff, and they had some different things kind of going on, and they had this huge reaction to things. Like let's say you had something like alcohol. You have a client, and you're like, hey, you're drinking a bottle of wine a night. Let's examine your alcohol consumption. And they're like, why do you have to go into that? Why don't you just stay, they're angry at you for bringing it up. Why would they be angry at you for bringing it up? If they were in a healthy place and they were like, yeah, that's just too much. Every night I'm like, I must just not do, but I just do. We really need to talk about that. That's more healthy than the resistance. Resistance is saying, wait a minute, you can't pull out from under me what I'm standing on. This helps me make it day to day. So what you do then is you're going to back away a little bit, give them something else healthier to stand on, and then remove the alcohol. That makes sense? If the alcohol is that critical to them, they're coping. Now, there's some exceptions to that. If something's really dangerous, if they're just overdosing on heroin, if that's not going to be like, hey, let's slowly back away from the heroin, that type of thing. But we do want to look at, okay, what can we do to really help make some progress here? That kind of makes sense? So, substance-induced anxiety disorder. Again, that is, you're going to find that around people and stuff too. Look at the prevalence rate though, is so low. We can look at this one, but you're just not going to see it that often. 0.02% of people is really nothing that significant. Anxiety disorder due to another medical condition. These are what you're going to see a lot. So you're going to see a disorder, and they're going to say in the DSM is make sure it's not due to another medical condition. And you're going to miss this one all the time because you just don't know every medical condition. Your clients don't know all their medical conditions. Like all of a sudden, I had a guy come in and say, I am doing so much better. I feel great. This is the best I've felt. And I would love to say, yay, everything we've worked with is working. But he was like, man, I just feel good. I had that conversation with my wife you're telling me to have. And it, even though it didn't go that great like we thought it might, but we really felt like we're in a better place. And I said, so what's changed? He said, I don't know, I've been feeling better, but you know what happened about 2 or 3 weeks ago, or 2 weeks ago when I first started feeling better? he said, I just got tired of taking my prostate enlargement medication, which is a hormone. You take a hormone to reduce the prostate size. And he said, I haven't had any prostate problems since then. I feel a lot better. So he stopped taking a hormone that was he changed his hormones and it was affecting his issues. So that's why we want people to get medical conditions. We want to know, check your thyroid. We want to know what's going on. You start throwing your hormones off, your emotions are going to go right on that roller coaster. There's no way to avoid that. I mean, you're changing all your chemicals, things are firing everywhere. So those are things that are going to affect these type of things. So if there's a medical condition that is causing it, it can make a big difference. Had somebody I was working with for a while, a wife, husband was in battle, had a severe injury, and had a TBI, a brain injury. And the husband's psychiatrist had pulled her aside and said, look, there will never be a cognitive change to his behavior. There's nothing we can do to make him better than he is now. And so you could work all day long with that person and be very difficult. You might be able to get the brain to rewire a little bit, but you could work for 10 years and not see the violent behavior he's demonstrating now ever change. And so, but again, that's not a matter of did counseling work or not work. That is, there's parts of the brain that are dead that did a function that no longer, so there's a medical condition causing that difference. So if somebody has a TBI, if they have a brain injury, if you start going through a process and someone's like my husband's and he just got to get angry and you're thinking maybe PTSD, he's had service in the military, maybe he's got something going on, and then you get into, he got blown up once and they examined the brain and they said it was a TBI, you have to look and say, okay, if there's a physical injury to the brain, we may not see normal responses to normal interventions. So you have to just be aware of that. It doesn't mean it won't get any better, but it means you have to have that understanding that you're looking for different things. So treatment implications, we're not going to get into that. Okay, DSM. I just want you to get kind of familiar with this. We're not going to read the whole DSM. You can read the DSM on your own time, and you need to know it. So, separation anxiety disorder, again, this is a very, very real scenario where people will have specific struggles separating from certain people in their life, different things like that. Just be aware of it. Excessive worry, loss of attachment. The most aggressive violence I've ever seen in struggles within a child has been attachment disorders. There is something about early childhood attachment being disrupted is absolutely probably the most traumatic thing that can be done to the brain from reactions I've seen. Well, I've seen behavior of kids that confounds what behavior they have running into a wall until they split their head open, or this just physical harm to themselves that is just has no purpose whatsoever. You'll come back to usually an attachment issue. And so attachment disorders are significant problems. So early childhood connection is absolutely vital in these areas. But if you're working with foster children, things like that, you're going to find significant attachment issues. And so I'll tell you about the kid in the police car. No. So I was working in foster care once, and a foster parent called and said, you need to come back to the house. So I come over to the house, and the child had a little boy, a little 6-year-old boy, 8-year-old boy, whatever, young. And he was trying to run around the house. So they were, the foster parents, they can't put their hands on kids, things. So there are ways to kind of restrain children, but they really have to call the police. They have to put their hands on a child at all, by law. And so the dad was standing by the door like this. The child's trying to run past him. Mom was trying to kind of keep him calm in the corner. So we tell him to call the police. He's trying to push past the dad, and so police come. We show up. Police come, put the boy. They try to talk to the boy. The boy is just growling, making noises, and trying to push past the police. So the police are like, we can contain him in the car. The car's designed with doors that don't open and things. So put the kid in the police car. He's in the back of the police car. He's so little. They're kind of like, I hate to even put him in the police car. It's not even really. So they feel kind of bad even putting him in there. He's in the police car. And he's just freaking out and he's thrashing around. He's kicking, so they don't want him to kick the window out. So they open the police car, and they have this little thing they put around the ankles, and they can tie it outside the door, or shut the door to keep your feet stuck to the bottom of the door. And so they put this, the device on to keep it from kicking out the windows. And he's wiggling around, thrashing around. They feel like they're villains at this point. The police do. They're like, oh, I'm a horrible person for this, doing this little boy. But the boy's thrashing around. So they call for a supervisor. And at that point, because they're going to take him to get him screened, a pre-screener, to see if he needs to be hospitalized, which he did. And then what happened was he's sitting there, and all of a sudden the police car, because I was standing behind the police car with the officer, and he said, yeah, we need a supervisor down here. We need him going to screen. He's been restrained. We have him restrained in the back of the car. He takes the bottom of the seat of the police car out, rips it out, and starts smashing it on the window. And I remember as him saying, Sergeant, he just ripped the bottom of the car out, the seat out of the car. So he ripped the seat out of the police car, smashing the windows with it. Little boy. So finally they do get in there, and they restrain him more, and they hold him down, and he's crying, and he's growling. And they finally get him. They finally get somebody, they're going to get him to the screener. The screener was going to come here. They end up taking him to the hospital, psych hospital. Take him to the psych hospital, and of course, you know what happens. He's exhausted, sleeping. He shows up for the screening, sleeping. He's the cutest little kid you've ever seen, sleeping calmly. And the cop is like, my legs and the seat was, I don't know, like, you know, they're like, and they're like, what? To the officer? What was happening, you know? So luckily they knew the boy, and we were like, look, he was struggling, you know, so they did hospitalize him and try to get him on some medication. But that's what you're going to see with attachment. So we're talking about separation. Separation can be a really powerful thing, and kids will often have this when they're separated from mom, or they have to leave for some reason. Like you'll see some issues with that. But a lot of times they'll have separation anxiety if something's happened. Like they were at school one day and mom unpacked, mom filled up the car, got everything out of the car and left, you know, and then they come home to grandma, and grandma's like, your mom's not here anymore, she had to leave, you know, then they're like, they don't want to leave grandma, they don't know if she's going to leave, you know, so sometimes they have situations go on where they have anxiety, and sometimes they have just this real profound fear of separation. And so you can get into that a little bit more too with some of the specific features of it, prevalence. And again, you got the differentials: GAD, panic disorder, agoraphobia, conduct disorder, social anxiety disorder, PTSD. You might see any of these things with that diagnosis. Personality disorders, anyways. Selective mutism, we talked about this already. But again, look here at the duration. It has to happen for at least 1 month.
At least a month.
Yeah. At least 1 month. I don't even know what that is. I can't see around the corner. I couldn't see the X on the screen sideways. There we go.
It's not limited to the first month of school.
So again, you've got selective mutism. Not super common, but you will see it. Again, disturbance not better explained by communication disorders, childhood, like speech disorder, language disorders. You know, that would be a better description in some cases than refusing to speak. But you will see this, actually. You'll see people, kids that struggle with this. Yeah?
Question. With the time limit, I've seen like that time limit thing quite a bit. Is that like the end all for diagnosing?
Yeah, that's a good question. For a technical diagnosis, yes. That is kind of, if they don't meet the criteria, like if you didn't have it at 12, you don't have ADHD.
Right.
But you know as well as I do, since something wasn't observed at 12 doesn't mean you didn't have it. So when they observe it, people are not often good historians. So you have to kind of unpack their history a little bit too, if you really think. Now, the big example of that would be, let's say there was a car accident and somebody has some kind of disorder related to that, PTSD or some kind of a panic disorder, and that you can go back to the event date. Then you may need time to pass until you can actually diagnose them with the PTSD or whatever. But yeah, that's pretty stuck. there's a way around some of that where people will say they have features of this or that kind of thing, but generally, yeah, if they're haven't been doing it for. I guess the biggest idea behind that though is to make sure they have symptoms for some amount of time, like major depressive disorder or major depressive recurrent. That the time frame on that's a big deal. You don't want to diagnose somebody with major depressive disorder because they've been sad for a couple weeks. But then you go back and you say, how long were they sad? When did they recognize it? Specific phobias, you're going to see those. Flying, heights are a big one. Airplanes are a big one. Interesting, a lot of people who are afraid of airplanes are afraid of tunnels.
Yeah, because enclosed space.
Yeah, what does that tell you? It tells you enclosed spaces.
Mm-hmm.
What's the benefit of that? What's the benefit of knowing that? Well, it's a lot easier. They don't have to buy an airplane ticket to be exposed to flying. So they can actually, go through a tunnel and then come back and you can kind of walk them through the feelings of what they did too.
Oh, so for doing
exposure, some kind of exposure or something. Yeah, exactly.
Yeah.
So sometimes it is flying, and sometimes you'll go through different things to kind of guide them through the thought of flying. Like their fear of snakes, you don't have to bring one in. To have them, go through it. But you can see a reaction from people with a picture. This is a picture of a snake. I'm just going to show you a picture of a snake. What are you feeling right now? You can kind of go through some different things, some calming techniques, those type of things. Now touch the picture. And you'll see reactions to even touching the picture. And then you'll say, okay, now imagine you're here or there. That kind of thing. You don't be like, okay, so next Tuesday let's meet at the exotic pet store. Okay, we're gonna pick up where we left off. I'm guessing there's gonna be a no-show, but just a heads up.
Yeah.
Anyways, people can be very afraid of natural environments, heights, storms, waters. What's really interesting about specific phobias is this is not a specific phobia per se, but there seems to be a generally higher rate of anxiety in our nation, generally, like political election freakouts or a storm. I mean, we've had some storms recently that people have just panicked over. I mean, like even the state of emergency of the hurricane that didn't hit us. Before the storm was even really going to hit us, which it didn't. There were evacuations in Zone A. People freaked out because they had to evacuate. Many, many people bypassed their logic and thought, I must evacuate right now. Like, I'm at a much greater threat because there's Now, the system is good. It's meant to say, look, the whole evacuation, what it meant was, we are declaring to you that we will not respond with emergency equipment to your house because it could be too unsafe to get there. So they're basically saying we are now exempt from giving an ambulance to your house or the police. Now, if there was no storm, would they go even though it was evac? Yeah, they would go. But I mean, they're trying to give you that hard line. But people really started feeling. I had clients that were really losing it, thinking the world's going to end, the storm's going to come, we're going to lose everything, And we've had clearer hurricanes coming. We didn't have that alert. So people are just generally on edge more. There's a lot of anxiety about different things and events and school violence or violence in the workplace or all these different things are just heightened, a real heightened sense of fear about specific things. Yeah?
Do you think it would be related to how the media portrays?
Oh, absolutely. I think there's a picture painted of things that is so colorfully fear-based that I think we live in a culture where we're saturated with it. And our mind has to constantly debunk things we hear that we're meant to be afraid of, whatever it is. Yeah.
Mm-hmm.
Where would you place this? Where, for example, snakes are feared in my country by most women. It's like, can you have a phobia that's
Gender-based?
Well, you can. Well, you can.
Community-based.
It really depends. It doesn't because someone's afraid of something doesn't mean there should be a phobia or a phobia of it. A phobia, it could be now if they never The difference is in our country, and I'm not sure exactly how your country is, but in our country, you're very unlikely to encounter a snake. You know, so if you freak out just from seeing a snake, I mean, it's just not likely you're going to ever even have that phobia pop up. You know, so, but if you don't like spiders, you don't like things, that's not necessarily a phobia. But if you like, if an airplane, you go into panic attacks, you know, then you're coming above that threshold. So remember, everything we see here, every single thing diagnosis-wise, there's a healthy level of it. Like mood swings. If you're not a robot, you're going to have moods. Doesn't mean you're bipolar, you know. It's like that's the extreme of it, right? But it's not like every time you have moods, you're like, and if you had no moods for a while, you're like, man, I'm bipolar. It's not really like, you know, you start questioning yourself, especially after this class, you know. But in general, like you can see mood swings, and if it doesn't reach a clinical level, it's not clinically necessary to diagnose it. Does that make sense? Kids are going to be moody. It's okay. You know, it's okay they feel down. It's not. If they're to the point where they are talking about ending their life and they don't want to live anymore, they don't want to come out of their room, they're not eating food, I mean, that's more clinical. Okay, this is severe. So you want to kind of watch that difference a little bit there and see. But so yeah, people are going to have those phobias, and so it depends. So they're afraid of heights. Maybe they won't go on top of buildings. So what? So they don't even care. They may say, I'm just afraid of heights. So if they ever do are like, hey, I want to get rid of my fear of heights, then you can help them with that. So I have people come to me and say, listen, in 6 months I'm going to a wedding in California. I've never flown an airplane before. I'm terrified of airplanes. I want to be better at airplanes before I go. I already have these medications to take, and I'm still concerned. And I'm bringing my daughter, and I don't want my daughter to freak out. If my daughter sees me freak out, she's going to freak out. And then she'll be afraid of airplanes. And I don't want her to be afraid of airplanes. So that's somebody who's like planning on, I'm going to have to fly and I need help with this. And so one of them paid for a $300 course online and was so angry because it was ridiculous garbage. Like whoever was up there was like, you know, and she was like, none of this worked. It was the stupidest thing I've ever seen in my life. Like, so yeah, so some people have tried stuff before. And let's go back to that for a minute as faith integration, which this is not at all how I would anticipate integrating faith in this classroom. However, people hate Christian books on anxiety. So I'm just going to tell you that right now. Because and this is the thing. The Bible says things about anxiety and things, and the way it's often interpreted or communicated is it makes you feel unchristian or unspiritual for having anxiety. It's like, like those whose minds are stayed on Christ are filled, and you're like, did you say my mind's not on Christ? You know, think about, you know, it's like I'm really worried about life right now. Guess whose mind's not stayed on Christ? You know, and so it kind of has that impression of like of this spiritual judgment that can be linked to it. The Bible wasn't written that way by the Holy Spirit. However, people sometimes when they say things, they have a very quippy thing to say. Like, I don't like anything in the Bible that can be on a bumper sticker in general. Like, that's just, to me, is like, ooh, that's rough. Like, you know, like people all the time, you know, the whole God is good all the time, you know, all the time, God is good. That's cool. Like, that's neat, you know, but anything like that, because there's always that person that's like, God's not good to me right now. Like, you know, I had a family I worked with a long time ago, and they had a kid going through something really difficult, and he had something good happen in his life, and he said, this is the first time I thought maybe God doesn't need me. You know, I mean, he doesn't think God's good. You said that to him, he's not going to go, oh, you know, maybe I'm wrong. God is good. You know, so it's a nice thing to say, and these things are nice to say. Sometimes are received by people that are hurting in the moment, and they feel less in ways. And so just be aware of that. And a lot of Christian books, from what my clients have said, were just not helpful. They were just like, just trust God. They would come in all like, yeah, if I would just trust God, I wouldn't need to see you, wouldn't I? You know, and just like that's what the premise of the book was, just trust God in your situation, you know. And it wasn't that easy for them to apply that. So they weren't at a place where that was really good advice. Obviously, if they encountered the living God and the author and perfecter of their faith, and he was at the foot of their bed, they would not be in the presence of anxiety. They would, you know. Now, I'm not saying that they haven't encountered God, but I'm just saying, obviously, if we're able to get to that place where that addresses our anxiety, we're in a good place for that. But just be aware, if you're a Christian counselor or you're not a Christian counselor, you're a Christian, that's fine. you're going to get people to come in that have read faith-based materials that did not work. And so just be aware of that and be ready to address that, and it's just the way it is. So I'm very, very careful. I go to Wave Church, and so they were doing a series on mental health a few months ago, 2 months ago. And so they called me in and said, we need you to do a training for all of our pastors, all the pastors by video all over the country. And so we need you to do a 3-hour workshop on what we can tell people about actually managing anxiety, because a lot of the stuff we come up with to say is just not working. We have a rampant number of anxiety issues going on in the church and depression. So I did a complete training on the stuff I'm going to tell you tonight with them to be able to present it and speak it on this topic series, because they wanted something further than what they were thinking. They're saying, look, what we've been saying is really not helping people as much. So anyways.
I think there's actually a verse in the Bible that says something like cheers with friends is like salt in a wound, or something like that. So it's like you don't want to be insensitive. That's the word I was thinking of, insensitive. A lot of Christianese books come across as being insensitive, or I can't think of the other word that goes with it, but just like you don't get it.
Yeah, I think it's not the fact that it's a faith-based book as much as a shame that can attach to somebody's spiritual walk from it not working. That's kind of the whole angle I think is really tricky. So I believe in what the Bible says wholeheartedly. So when I speak that with people, I'm thinking in the back of my head, what's they like to hear that? What if they've tried that and it didn't work? What if they still lost their marriage, even though they stood in faith and they professed their faith and they did all these things right? So we have people who've experienced things. What I often tell them too is, with Shadrach, Meshach, and Abednego in the fiery furnace, that whole thing, there was no example of that happened earlier. Nobody was in a furnace and lived ever. So there was never this example those guys are leaning on, oh, you remember those 3 guys? They survived, right? There wasn't any of that. All they knew was God loved them. God was able to do anything. And if it was his will, they would live. They rested in the character of God when they didn't know his hand directly what would happen. And that's a good thing to help communicate to people, is that, the character of God is good. I've told people this too. God is better to us than we could ever be to ourselves. If you had unlimited resources and could give yourself anything you wanted, unlimited money, unlimited health, unlimited everything, you would not be better to yourself than God is to you. We're just not capable. We're coming from a completely different foundation. So we have to rest in the character of God when we don't see what's happening with the hand of God. Knowing that God is good, knowing that something good will happen from this, and that he has a story here that will be told for generations to come that is far surpassing what immediate relief we would like right now. So just kind of keep that in mind. That being said, that's also what you want to be careful of talking to people about divorce and things like that as well. Because sometimes people will tell you, well, I know God hates divorce. I had somebody in a really, really dangerous marriage, and they were like, I know God hates divorce. And I said, do you know why God hates divorce? Probably, to say I should not get divorced because God hates divorce. Yeah, God hates divorce. It's a violent ripping apart of something not designed to be ripped apart. That's the reality of it. And it's a picture of Jesus chose that image, God of Jesus being the bride, the church being, Jesus being the bridegroom, the church being the bride. There's an image of the relationship. It's a living metaphor for everyone to see of the image of Jesus and the church. That's why all the submission stuff is in there, and all the love stuff is in there. There's 6 times more Jesus says to love your wife than he says wife should submit to husbands. So that's all thrown out of whack in Ephesians. But the trick is, though, it's easy for an equal to submit to somebody who has that much love and care for somebody. We submit to each other, brothers in Christ, so we do all those things. But the trick is that it's a picture of the love that Jesus has for the church. So when marriages are shredded apart and families are disintegrating, it's hard for people to see that. Hard for kids who don't have a dad to understand a Heavenly Father. To even understand those words is hard for kids who have not had a father in their life. They don't get it. Or their father's not like that. And they're like, I don't know, God's angry. People have these views all the time, these automatic views. You see really young children who are like, man, God just hates me. Well, why do they think that? Because their dad abandoned them? That's their view. That's their picture of what God would be like in their life. So obviously none of our fathers are like the greatest example to follow for God. Except for some dads here maybe y'all have like great ones. I would strive for that, but I don't think I'm in there either. But at the same point, it's really this whole example of of who God is for us. So we see a big difference there with people when we look at these things, because a lot of people will hear these statements and have a lot of judgment on themselves about them. People will also see sometimes maybe the grass is greener. That person found somebody that really loves them. Maybe if I got rid of this guy, I could find that guy. So sometimes people kind of will see a story or a testimony and think, that is the better side of things too. So you really have to be careful with your story and stories that you tell and where people are, to not give them that level of condemnation or really load any kind of meaning on top of things that really causes them to be filled with shame and these other things. At the same point, challenging them to walk up into what they have to walk into and stuff. So a little confusing, but moving on to DSM a bit. You'll see a lot of the same differentials here, but those are good things to learn. Is schizophrenia, this is an interesting one too. Psychotic disorders, eating disorders. So why would somebody with schizophrenia, or somebody with a social disorder, appear to have schizophrenia? Or let's say maybe they're schizophrenic, but you're seeing them come in as a social disorder.
Could be the personality that they have. I don't think it's
You think DID?
Thinking of DID. That's what I was thinking.
Yeah.
Can schizophrenia cause you to withdraw?
It can. That's one of the signs of schizophrenia, is that people withdraw. Because remember, they're hearing voices. A lot of them know they're hearing voices, or they're seeing things, and they have an alternative reality going on with them in the world they're walking through. So a lot of them don't necessarily want to be around people, because people are like, who are you talking to? And they don't want to explain it. So if they even know, that's not they're having a complete psychotic break. But a lot of times they want to shy away from being around other people because they are in their own mind in conversations, seeing things, and they don't want the interaction with people. They don't want people to notice it. I often thought, if people aren't going to get treatment for schizophrenia, we should give them earbuds. Like, just give them one. Because, if you walked around, you ever see somebody talking, you're like, who are they talking to? And then you see it, and you're like, oh, they're on the phone. Yeah. I say just give them an earbud, let them walk around the boardwalk. Go for it, man.
United States now.
Go ahead and walk around. If you're not trying to hurt yourself, trying to hurt anybody, and you're just kind of, we don't need to know who you're talking to.
It's like, I'm hands-free.
Yeah, so, but again, those people are going to avoid social interactions in a lot of cases as well. And the paranoia is a whole other thing. But yeah, that can present itself as social anxiety. They don't want to be around groups. They don't want to be around people. And then you start unpacking that a little bit, and they have some super unrealistic beliefs. That's because they're coming to get me. Who's coming to get you? These people are coming to me. I've had people so convinced I believe them for a minute. I'm like, not that one, but I mean, like, maybe this is, this person's trying to poison me because of this, and they've tried before, and and I'm like, there's a fine line. Either this person's seriously trying to do this, or there's sometimes people will tell you stories, you're like, I don't know if this is real or a delusion. This is such a good story. I had, some time back, I had a client that was a target of a hit by mafia. And so, like, going through the whole story, and like, and the whole details of it were like, they went to the FBI with all this evidence, and the FBI is like, here's the this is not funny, but they said, here's the problem. You have enough information to get yourself killed. but you don't have enough information for us to protect you.
Mm.
And so that's a bad place to be.
Oh man.
But yeah, he was he had a couple hit attempts against him and things. So for a while, I was like,
You weren't scared.
"Is this real? Why would I be scared?"
I don't know. I remember talking to you.
I don't know. I was kind of like, "Is this even real? Maybe this isn't even real." You know, and then just some of the details and doubling back on the details and some of the things that happened after that. And after a couple sessions, you realize, all right, it's probably part of their story. You know. Of course, what kind of diagnosis do you think he's struggling with, among other things, maybe? Yeah, anxiety. Clearly, like, you know, a little anxiety where you're, you know. I don't know about y'all, but I didn't think about my car when I started it today. All right, so that's all I'm saying, right? You know,
Check.
you know, some people pay more attention to that click when they start their car than other people. But I mean, I'm good. I was good today. I wasn't even worried about it. I was like, what? It started again? It's a good day. So yeah, you want to watch for these fears. Social anxiety disorder, social phobias. Individuals fear they will act in a certain way to show anxiety symptoms that will be negatively evaluated, which is a nice way of saying embarrassed. They'll have a panic attack, those type of things. Social phobia is a big one people have quite frequently. I'll show you how to treat that in a minute. Trust me, this is the boring part. We'll get to the good stuff in a minute. Again, medical conditions, you can look at some of the other things there too. Panic disorder, we already got into. Look here how much of the panic disorder is physical. Chest pains, nausea, abdominal distress, dizzy, lightheaded, chills. So that you're seeing somatic complaints. That's the word for it, somatic, which means in their body they're actually feeling complaints. So you're feeling all these things happening. So panic is going to be full body. It's not just going to be emotional. It's going to be a little bit different in that. So fear of dying. Yeah, there's a lot of them. I think the part of this that's really difficult for most people with panic disorder is the fear that you cannot be in control. Like something can happen to you and you can't control it. And it can happen whenever it wants. That's a bad feeling. So let's back up in that experience from somebody who may have made that statement that I just gave you. Let's rewind a couple of years earlier, and I'll tell you this much about their story. Time does not heal wounds. If time healed wounds, we could save thousands of dollars by not being here and let people just heal on their own, okay? Time infects wounds. It doesn't heal them. And when people bury things to function, things decide when they will come out. Okay, they don't go away. So they may feel better, they may be able to function temporarily, things will surface that were buried. You can count on that. And so people often with panic disorder and other things, they bury things for some time, all of a sudden they surface. I mean, I've told you a story, but worked with a lady driving down the road, couldn't breathe, thought she was having a heart attack, drove to the hospital, collapsed in the emergency room, couldn't find anything wrong with her. They inserted a monitor under her skin that she could hit every time she had a heart problem. It would communicate with the cardiologists for years trying to deal with all of it, and found out, in fact, that it had nothing to do with that. It had to do with her mother passing away 3 years previous and her never dealing with the grief. And so here she, of course, then had agoraphobia, wouldn't drive a car again because she almost lost control of her car. First time ever. And so the only way we could get her to drive again was for $99, you can buy a mirror, a rear view mirror that has OnStar in it. Because she was always afraid her cell phone would be dead. She wouldn't be able to get help. Her husband had to take off work for 6 months, driving her around to doctor's appointments. And so he worked in a job where he had some freedom, but he would come back to work, come back home from work, go to work. She would drive nowhere. He drove her everywhere. She wouldn't even sit in a car at night. It took us a long time to get her to the place where she could actually get some help. On a cool note about her is one thing I did to help her with her treatment was I let her record every session. So she audio recorded every session and she would listen to it 3 times a day. So it was like having therapy 3 times a day. So she would go home all week and listen, and then she would transpose all the key things that I said into a notebook. And she carried that notebook everywhere. So if she would ever have any kind of feeling, she would open the notebook and go through the different tools and things I gave her to do. What was really neat was when she left treatment, and she's all completely better now. She gave me the notebook. So I have like a copy of the notebook, which is kind of neat because I have like a whole treatment protocol that worked really well for her. And I was like, I didn't say that. Like and things I never even really said that are written in there. And she said she copied down from me. So, but I was like, that was pretty cool. I didn't even know I said that. So I have a lot of things that I've used in the past from that too. So I have a copy of it. It's kind of cool. I recommend clients audio taping sessions for that reason, to be able to go through it. It's really popular. I worked with one of the best. So in Hawaii, when I lived in Hawaii, I was a pastor of a church there called New Hope Oahu. It was a huge church of 18,000 people, and there was a lot of people coming through with a lot of different issues. So I got to meet a guy who was the state's leader. This guy was the leader in Oahu of trauma work, and he focused primarily on domestic violence. What you probably don't know is domestic violence is 7 times higher than any state in America in Hawaii. So they have 7 times the incidence of the worst state in America on the mainland of domestic violence. And it has a lot to do with everybody's living together, extended families. It's very expensive to have property there. And then you have the whole warrior spirit of the Hawaiian culture, with men being the warriors and all this kind of thing. So a lot of power differentials within marriages, families, and extended family. So what he would do, though, he has a notebook. I'll try to bring it in for you. He has a book you can buy. That's a workbook he goes through with clients with that he wrote. And he has in the notebook, though, that goes with it, he records. You record all your sessions. And what he'll do is have you go back through and then recall. When you come back to see him the next time, he wants to hear what your observations were from the recording. Because he will lead and give teasers of like, maybe you should re-examine this. Maybe you could, now this is your story, tell me that again. He'll go back through, and you can hear him kind of pointing out discrepancies in the story that hopefully they'll catch later when they go back to listen to it. So that's kind of why he does it. He's a really fascinating guy. But I don't remember his name, though. I'll have to get that for you later. But I have this book in my office if you want to see it. But again, those type of things can be really helpful. With anxiety disorder, it was good for me to have them recorded. See where we're at here. We're getting toward the end a little bit, I think. Panic disorder is a big one, obviously. You can see panic attack specifiers. You can get into that too, a little bit what they are for recording. The nice thing is you can make notes on your intake, and then you can go back later and pull up this book, open it up, look at your specifiers or what. Agoraphobia, we have that already. We covered that pretty extensively. Fear of going outside. Again, look at some of your specific phobias. We already talked about this a little bit. Other medical conditions, separation anxiety. GAD we looked at, restlessness, being on edge, easily fatigued, difficulty concentrating. We looked at this already as well. Got a good idea on that on GAD. Substance induced, we talked about that already too. And here's all the substances. Caffeine's a big one. Caffeine greatly induces anxiety, so that's one thing you'll want to look at if people are really struggling from that.
Increases anxiety?
Mm-hmm.
That makes sense with the stimulant.
Yep, it's a stimulant. Anxiety due to medical conditions. We got into that a little bit too. And there's other specific anxiety disorders as well. That's one. So if they may have, like we said, they have one that doesn't really fit, you can go with this one as well. And you can go with unspecified anxiety disorder. So let's say they're not generalized, but they don't have a specific phobia, but they have come in, you can go with this one. So let's talk about treatment protocols, because it makes sense to figure this out when you're considering anxiety in general. So let's start off by saying anxiety is not a disorder, since we just studied this. These are disorders. But anxiety itself is a normal part of function of the brain. Your brain's job is to predict. It is constantly trying to predict what went on, what is good, what's working, and it's trying to protect you and create a list of threats. So the brain is constantly looking for threats to your well-being and give you the upper hand on that as well. So what happens is it's trying to kind of keep track of that and make sure you're safe. So let's say my wife was sitting in this chair right here, and a little white fluffy dog came in, little tiny little dog. She would be heightened. She'd say, why is there a dog in the classroom? Does anybody have the dog? Does anybody have a leash on the dog? Whose dog is it? Now, if a German Shepherd walked in here, she would go, oh my gosh, stop the class, there's a German Shepherd, how cute. Because when she was 6 years old, she was bitten by a little white dog. So 6-year-old brain is cruising through life thinking nobody can hurt you, everything's wonderful, life is beautiful, feels pain out of nowhere, and the brain immediately says, what causes pain? We have to stop this from happening again. Little white fluffy dog. So it creates this list of adjectives in the brain. And this list of little catalogs running through the brain is like the always looking for threats, scanning for threats. What's going to hurt us? What's going to hurt us? Little white fluffy dogs. So people with anxiety are exhausted. It's exhausting to have anxiety because your brain is constantly scanning for threats. And so you're constantly looking for those areas of like little white fluffy dog. Now, the problem is, like in Virginia Beach, I walked in here too. I didn't see any polls, like little pictures posted outside the building here of watch out for Froofy, little white attack dogs running around campus, just not happening, right? There's just not a list of them. And so what we learned from anxiety in the brain is that anxiety system of the brain does not work on data. It works on emotional strength, triggers. Data and triggers are completely different. And this is how we treat anxiety, because we're going to confront triggers with data. To give you an example, I had a patient once come in. She had a very close friend who was in his 30s, maybe. He had a 2-week-old baby, really having headaches and stuff. Baby was born, he thought they'd go away. Went to the emergency room and said, it's really bad now, I'm taking Motrin, it's not helping. Goes in the emergency room, they said, you have a massive tumor. He never made it out of the emergency room. He died 2 days later. And so 2-week-old baby, wife, brand new marriage, just devastated. Well, client knows this people and says, I've been having headaches. So the emotional trigger is there. Sometimes we have headaches and we die right away. So goes to doctor. Doctor says, well, you have migraines. And she says, no. I need to see a neurologist. So the doctor's like, okay, fine. Sends her to a neurologist. Neurologist says, you have tension headaches in the back of your neck. They're triggering your migraines. I give you medicine for both. She said, I need to see another different neurologist. Goes to second neurologist. Second neurologist says, you have these headaches in the back of your neck, these tension headaches are triggering your migraines, and I can give you medicine for both. And she said, I want a scan of my brain. The doctor says, it's not medically indicated for you to get a scan of your brain for migraines. But so you may be paying out of pocket for this. And she said, I'll pay cash for it then or whatever, but I need a scan of my brain. She goes and gets the MRI done or whatever, comes back, brain looks perfect. Nothing in the brain. That's abnormal. And says you still have migraines that are causing your headaches. She said, I want the scans to go to a third neurologist. Goes to a third neurologist to read the MRI and says, you have tension headaches that are triggering your migraine headaches, and I give you medicine for that. Sends her back to her primary care. Her primary care picks up the phone and sends her to me. And so what we did was we linked the brain, the actual scan of her brain to the headaches and said, look, we know it's not a tumor because there's no tumor in the brain. So when we link the data to the trigger of what would that illness be called? What does the client have? What could you say? What? Yeah. You could have like the old hypochondriasis. It could be that, which is now changed to illness anxiety. It could be
illness anxiety.
You could go with any option thereof. That any kind of unspecified, even if you wanted to. But she doesn't have a medical condition. She has a fear of a medical condition.
She has a fear of a medical condition.
Yeah, so it's not going to be from the actual medical condition. So you see, you got that kind of. Now, let's say somebody had cancer and had a tumor removed, and they're afraid they have a tumor. They had a medical condition, and now they're afraid they're going to die from cancer. That would be a link to a medical condition. So, but she didn't have any. She has migraines. You could say something linked to the migraines, but more it better fits in the fear of an illness.
Mm-hmm.
So she was able to be treated in 6 weeks. She was completely fine. And so it doesn't take a lot of time if people do the work for the anxiety to kind of treat anxiety. But so the general idea here is just understanding that a little bit too, is just the understanding of how anxiety works in the brain is the big thing. You just have to understand that the brain is linked with this system. Now the system's not defective, okay? Here's what happens though. The anxiety center of the brain is back in the amygdala. It's way back in the back of the brain, which is cool because like it's closest to the brainstem. So like if you saw something scary, you react, you know. So picture caveman, right? Life's a little simpler back then maybe. You know, caveman sees friend eaten by tiger and goes, ooh, those big furry things are dangerous. And so back of the brain says tiger's bad. Next time he's cruising around, walking around, and he sees a tiger, and he goes, I'm going to run. The amygdala says, run. He takes off running. He's flying. He gets back to the house fine, shuts the door. Tiger doesn't even follow him. He lives. The center worked good. He stayed alive because of the amygdala. Because the amygdala noticed the tiger. Because that was a good threat. And he evaded the threat because of that. So that's a good function of anxiety. That's how it's supposed to work. So, you know, you don't need other things working in the body like that. And this is the problem. When the amygdala fires, for whatever reason, the other parts of the brain get shut off. It's kind of like an efficiency. You don't need confusion going around the brain when you're trying to evade a threat. You're trying to get away. So when the amygdala fires with anxiety, the prefrontal cortex shuts off. If you look at brain scans, you'll see there's nothing going on. There is no activity whatsoever in the brain in that area because you don't need to rationally sit around and contemplate life and thoughts of life and have that processing going on. You need to run. You see spider, you need to jump because the higher you get in the air, the spider will be there. Rational person says, I'm going to come down right where I jumped. Maybe jumping wasn't the best thing to do. Mm-hmm. But the rational part of the brain didn't decide to jump. It was the amygdala. The rational part of the brain's not working. So we have to get people, when they're in fear, anxiety, any of those trauma type base, we need to get them back up to the front of their brain. And so when we're working with clients and we need their brain to be back to functioning normal, we need the rational brain to work, we need to use empathy. Empathy is the best way. So when someone's angry and you can be, or they're afraid, it must be difficult that you really feel like this is going to happen. Eventually you're going to get them to go back to the rational part of their brain quicker. Empathy works great with foster kids, it works great with attachment issues. Kids would come in, we had foster kids all the time come in and they would, you know, so foster kid's supposed to be in by 10 o'clock. Foster son comes home at 1 a.m. How do you think he comes home? What's it like when he comes home? Does he sneak in? Quietly, make sure the door doesn't squeak, get back to his room? Nope. Nope, he comes through the door loud. Slam, door flies open, slam, door shuts. He's not afraid. He knows there's going to be a confrontation. He's used to the adrenaline firing, and he likes the adrenaline firing. He's very comfortable with fear going on in his world. He's not. That's normal. That's what happens in homes. He doesn't need to be quiet and be all like, hopefully I won't get caught. He comes in loud, and so he wants to fight. He wants the adrenaline firing. The amygdala is firing. So what we train foster parents to do is come in and say, I'm really glad you're safe. I was very worried about you. Here's a washcloth, a towel. Just go get cleaned up, get some sleep, and we'll talk about it later. And turn around and walk away. You don't even deal with it there. And he doesn't know what to do with that. Because you showed empathy, and you totally evaded the fight that he wanted. He set you up for the fight, and you didn't take it. I've had kids punch holes through walls because they're angry, and say, listen, do you feel better now? It must be really difficult that you feel you have to punch a hole through the wall in order to deal with your anger. You know, why don't you just take some time and we'll talk about it later. The next day, foster father comes in and says, hey, Hey, let's talk about what happened yesterday. He's all calm now. You must have really been frustrated. Yeah, I just was this and this and this, and that's got to be difficult. Hey, you know what? Let's go to Lowe's and pick up some stuff. I'll show you how to patch a wall. Literally drives a kid there. They patch the walls together, repainted. The child's like, I'm so sorry. I did this. Completely different. You totally evaded the whole confrontation to escalate the amygdala, and you dealt with the brain differently. So you can teach people to handle the brain completely different. That's a way you'll produce a different outcome. That being said, you have this anxiety. What happens over time, back to my wife, when she was 7, 8, 9 years old, she realized not all the little white fluffy dogs bite us, because she saw a couple of them, you know. And so, but to this day, her brain is still like, they don't all hurt you, but some of them do. You know, so to this day, like if we go for a walk, she sees every little white fluffy dog within 150 yards. I haven't seen one since 2007, just in general. Like I don't know, I'm sure they're around. If you have one, that's great. I don't care for them. I don't dislike them. I don't like them. I don't care. I just don't notice them. I just don't see them around. My brain has not been trained to try to find them. Her brain has been trained to look for them. And so her brain reacts differently to them than my brain does. And so that's how we do. We come up with these triggers. So here's what happens is you have this breakup from this guy who's no good because he wasn't responding to your text, and he was ends up he was over with some other girl, and you're all like, fine, that's what you're gonna be. I'm out of here. So you're alone. Now you're like, your brain is like, ow, that hurt. What did we miss? No answering texts. Didn't say he was going to be where he said he was going to be somewhere. You come up with this list. So you're like, I'm moving on. So you move on, right? You move on, and now you meet a new guy. And new guy is like, awesome guy. He's nice and stuff. And then you're like, oh, he's cool. I really like him. Finally, I got a good one. God gave me a good one finally. And then and then you're there, and then all of a sudden you're like, man, you know, something in your brain, because your brain gets comfortable. Now your brain's like relaxed, and you're vulnerable. That's the V word, vulnerable. You're vulnerable again. Your brain's like, ooh, don't go there. Don't be vulnerable. You got to be hyper vigilant, because that's how you're safe. You're not safe when you're vulnerable. That's what the brain's telling you. So the brain likes hypervigilance. Be ready. If you're not ready, you're not ready for something. It's going to happen. It's not going to happen if you're ready. But if you're ready, you know. So the brain wants you to be elevated. So when you start relaxing, all of a sudden your brain's like, you can't relax. You start having triggers. Brain's like, whoa, 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 don't do that. Don't do that. We're not safe when you do that. So all of a sudden you're sitting there and you're like, well, what is he doing right now? I wonder what he's doing right now. When you're in class right now going, what is he doing right now? I'm not pulling my phone. He's probably going to look at me and think I'm texting him. But what is he doing right now? He knows I'm in class. He knows I'm in class. What is he doing right now? And you text and you're like, what are you doing right now? You know? And then, 3 minutes go by and no response. And you're like, oh, no, he's not. He is not. Because now you're not responding to his actual behavior. You're responding to the last guy's behavior, right? It's the last relationship you had that you're actually... So he's going to catch both barrels from you in about 15 minutes. Because now he's paying for the sins of another, right? You are bleeding from another relationship onto this one. Does that make sense? Yeah. And so that trigger is there, and you're going to have that trigger. Now, if you've lived long enough, you're going to have these triggers, right? You're just going to have them from different places. But you just have to be able to understand that, so you can have that concept down a little bit of what the triggers are, of what you're experiencing, and knowing that they're your brain's method to try to keep you safe. Here's the problem. It doesn't work on data, so it's not accurate. It doesn't mean it'll happen. It's not predictive. Your brain being ready does not mean it's actually going to happen. You can walk around hypervigilant all day long, and things never happen that you expect to happen. Because the brain's job is not to actually accurately predict. It is to predict. It is to keep you vigilant and ready. So people walk around with a sense of hypervigilance, always being ready for something to happen, always looking for what's going to happen. Are they going to do this? Are they going to reject me? Is this person going to do this? I'll bet they're going to do this. How many times someone comes through the door and all of a sudden you tell by the way the door closes what mood they're in, and you immediately put them in a box of how much you're going to deal with them tonight. They come through the door, you're like, and you hear the door slam, and you're like, oh, never mind. I'm not going to deal with that. I think I'm going to have that attitude here tonight. You're immediately already like, there's an attitude downstairs. I'm not going to deal with it. To the point where if you grew up in an abusive home, you knew when dad came home drunk. and you smelled alcohol on dad, and alcohol's a trigger, something bad's gonna happen. I mean, to this day, you smell alcohol and you're like, I don't wanna be there if alcohol's gonna be there. Something bad's gonna happen. And it's a trigger from childhood. So we have a lot of those triggers. In fact, a lot of things go back to childhood. I had a client recently working 15-hour days, highly successful, makes a ton of money, great work, does really cool stuff for his job. And but his relationship struggles. He's just not as present with his wife. It's a hard time. And I was like, I wonder where you're, because remember, all behavior, and this is good to know, all behavior has a reward. Every single thing people do gives them some kind of reward. The worst things my kids will ever say to me, so there's 3 words, and there's probably a lot of other things they don't say to me, but I don't know is a big one. I'm like, I don't know. Why are you doing that? I don't know. Well, we're gonna find out why. Because you're getting a reward something. You get some behavior. I don't really have a reason. Oh, you do have a reason. We're gonna explore that reason. Because there is one. Because so I want to know what reward they're getting from that behavior. Every single behavior. You cannot not communicate. Everything you do communicates something. It's impossible to not communicate. So you communicate by your body language. You communicate by everything. There's always a reward from behavior. So I want to know what's going on. So I'm like, working 15-hour days. What's the problem with that? Why do you have this, And so he's just thinking, we're processing through it a little bit. And he says, you know what? When I was a little kid, I was like 8 years old. I went to my friend's house, and they lived like on this farm. They had this ATV, and his dad said, why don't you go out and plant some trees, these little trees in this back of this bucket on this ATV. I'd never driven an ATV before, but I went up to the holes where he wanted me to plant, and I put a plant in each of the holes, and I don't know what I was doing. He kept yelling, like, that's not the way you do it. And I went back, tried to fix it, and I don't know, I was a kid, I don't know. I came back, and I saw my friend the next day, and I was like, hey, how'd it go and everything? And his friend said this to him. His friend said, my dad said that was the hardest $45 you ever had to pay out to anybody because you were worthless. Since he was 8 years old, he said, that will never happen again. And to this day, everything he does, his work ethic, is surrounded by that one statement made by a very unstable dad, from what he describes, back when he was a little kid, about something he did to help around the house. So everything communicates. It all goes back to some feature. There's something that we're doing. There's a protective feature. There's something we're trying to prove. Keep in mind with your clients, too, sometimes people aren't trying to accomplish certain tasks. So let's say back there in the corner is a chair, and every time you come in, you're over in the chair. And, or better yet, like right here. Let's say I stood in the corner here, and you come in, you're like, man, Dr. Howland loves that corner. Must be warm over there. It's like, and I was like, man, he just won't leave that corner. The whole time you think, I just love the corner. Man, I love being in the corner. Corner is the place to be. That's what you think I believe, right? And so you're even thinking, at the end of class, we should get a bug for him that says, enjoy the corner. Because he just loves the corner. He loves the corner so much. The truth is, Dr. Howland hates the door. And I want to be as far away from that door as I can be. So I'm going to stay in this corner. And our clients are often in that position where it's not that they like doing a certain behavior, it's they hate the opposite of that behavior so badly. They're going to do anything but that behavior, so they're going to stay over here. I want to be this, I'm going to be perfect and control everything I do because I'm not going to be that person. It's not because they want to control everything, it's because they don't want to be that out of control. They're afraid they'll be out of control again. So sometimes we are avoiding things with our behavior as well. But a lot of it goes back to triggers. So when you're treating anxiety, you're going to address a lot of, thought patterns that are not accurate. They're called DATs, dysfunctional automatic thoughts. And there's a lot of them. There's a whole list of them. You do a search for DATs, you're going to be able to see a bunch of them. And I'll try to give you worksheets on them too. I have whole manuals on this. And so the DAT, though, is like these thoughts you have that are automatic, like hypervigilance. If you're alert, if you're ready, you're going to be safe. It doesn't mean you're going to be ready. It just means you're going to be elevated. You're going to walk around in a state of elevation. But you have to remember, though, parts of the body start shutting off. Things start shutting down that need to shut down when you're walking around in a state of anxiety. There's a good book I think I told you about already, Why Zebras Don't Get Ulcers. You can download it in a PDF. It's online. But again, that book is all about what shuts off in the body of a zebra when it's running from a lion. Biologically, things start shutting off. The body starts reacting. We don't need certain parts of our brain. We don't need certain functions when we're trying to evade threat. And so anxiety is that heightened sense of threat. There is a fear somewhere that's being avoided. And so what we want to do is identify those triggers so we can link data to them. Because it doesn't mean you have a brain tumor because you have a headache. Because you have a scan in your brain that says you do not have a tumor. And they create a mantra. They create a pattern of what they're going to say. I teach people to preload. When you're going into a situation, this kid who wanted to go to this concert, I said, if you want to go to this concert, you're going to go in, here's what you're going to say to yourself. You're fine. How many people are around you immediately? 3, 4 people. You're in a room full of thousands, 10,000, 20,000 people. But you're going to have 6 of your friends right around you. Those are 6 people you need to worry about. Stay right where you are. That's where you are, the 6 people. And you're going to be fine. You're going to be fine because there's nothing that's going to happen aside for those 6 people. You're going to stand there in a row and you're going to listen to music. Before you go in, you're going to say, I'm going to be fine. I'm going to go in there, I'm going to stand there, and if I do have a problem, I can walk outside of the building. I'll walk out of the building and I'll wait outside for my friends if I do have a problem. So if you do have a problem, you can easily walk away. Here's what you can do. So we give him a plan and he can preload. It's kind of like getting ready. So I scuba dive with my family. It's one of the things we do. And when you scuba dive, you don't go underwater. Any of you ever scuba dive before? Okay, that's sad. That's sad, it's only us.
Yeah.
Oh, phobia? Oh, we can work on that. Field trip. Okay, now. But if you try scuba diving, when you go underwater, pressure builds in your ears. And you get squeezed. Your ears start pinching. It hurts. And so what they tell you to do, I was always, when I was new to scuba diving, I'd go underwater and I'd be like, ooh, look at the fish. And I'd be like, ow! I'm like, this hurts. So I figured out pretty quickly, people on the boat would start squeezing their ear and blowing air into their eustachian tubes to balance the pressure before they ever got in the water. So they'd overpressurize their ears on the surface and keep doing that on the way down so they would never feel the squeeze. Every time the squeeze would come in, it would be normal. And so I was like, that's a cool idea. So I started doing that and never had any problems. It's the same thing. When you know you're going into some place that's anxious, an anxious situation, you can counter that with data. You can give actual facts. I'm afraid of a car accident. I'm afraid it might be a car accident. Well, how many miles have you ever driven? I'll ask clients. I don't know. What about your lifetime? Since you're driving, you're 55 years old. You've been driving since you're 16. How many miles do you think you drove? A million? Yeah, maybe a million. How many hours do you think you drove total at time? Like we had to guess, how much you've driven. Maybe 2 years of your life already you've driven, actually spent in a car. And so car accidents take about what? I don't know, maybe 5 seconds, 10 seconds from a window. So how many car accidents have you been in? Well, I haven't been in any. I saw one once. That was really bad. I saw a couple. Okay, so you've got 2 years worth of driving, and there's a 5-second window in there that something might happen, and you are literally going to avoid driving in a car because of that 5-second window. And then so you can challenge it and say, okay, what are the chances? And if there is, a lot of accidents are not that serious. The car wrinkles, it bends, it does its job. You may have some mild pain, some discomfort, but maybe nothing. So they're not all tragic. And some of them, sometimes things happen we can't control. But in a lot of cases, you drive safely, you can avoid some of these things. So, so you can start challenging and refuting these triggers with actual data. Just because he didn't answer text doesn't mean he's cheating. That means, what it means is you have a conversation. You say, look, when you don't answer text, I know sometimes you're at work and you can't. When you don't, I just want you to know it's like for me. I have a hard time with that because of things I've gone through in the past. You just need to know that. So couples will have that problem. They'll say, look, I'm going to, if she gets loud and starts yelling, I'm going to leave until she calms down. Well, her trigger is abandonment. One time her last boyfriend never showed up again, never texted, never called. Ever had that happen, by the way? It's very, very common for people just to be like, yeah, great time, never hear from again, apparently. But anyways, they have this happen, and then it's like, you walk out the door, she's loud, she's angry, she's struggling with something, and she's like, yeah, this is not good. So he's like, fine, I'll come back later. Doesn't say that though, leaves. She's thinking what? He's leaving. So now she's triggered by abandonment. You will not leave, you will not, and he's like, whoa, I'm trying to get away, keep this calm, And so his coping strategy for that situation is literally her trigger. So that's where you have to have that communication for these type of things. Panic is a lot harder to treat. because it is just random. There usually isn't a trigger. You have to look for things. Now, what I do with the panic is this. This is everyone's capacity. I actually used this cup today for this illustration, so this is my illustration. This is your capacity for stress. You may be here, and things will happen, you're fine. But if you're walking around up here, anything will put you over the edge. You can panic for whatever reason. Remember I said things come up when they want to. So you have something happen and you bury it. You're like, I'm just gonna bury that, I'm gonna bury that. And then you finish your master's degree. And you're like, woo, no more school. And all of a sudden, and this is very common right after school, you may have already seen this in your undergrad. Right after school, you're like, whoa, your brain's like, what? We don't have to study? We have nothing to do? Cool, I got some stuff we can do. And all of a sudden you start getting stuff and you're like, whoa, where did that come from? That came from stuff you buried under your busyness of school. So sometimes people are career education students because they see the benefits of great education. They're like, yay, this is great. The other benefit is you don't have to deal with your stuff while you're burying it under your busyness. Because then in the middle of your night, so your brain, so you find anxiety popping up like 4 in the morning, 5 in the morning, because the part of the brain that polices it, the part of the brain that's sitting there going, don't think about that right now. We got stuff to do. We have to do stuff. We can think about that later. Well, that part's not awake at 5 in the morning, but the part of the brain that's worried is. So if you ever have those things at 4 in the morning and you're like, is that my car? You know, or those, you know, is something going on? What's going on outside? You know, you just have this panic, or did I pay that bill? You know, or whatever. Or, you know, I mean, like to this day, I think I told you, I still have the 11:59 wake up to see if I posted something. Like Saturday night at 11 o'clock, I'm still like, did you post? I'm like, I'm a professor, I don't have to post. I don't have to post. I should post something anyway. So I should just post, hey you guys, I'm posting. This is me posting, so I can alleviate my anxiety because I still have triggers. It's obviously not data driven, I don't have to post, I'm not a student anymore. But I mean, I still have, the clock will strike a certain time and I will then have those because I missed a couple posts in my career. And now it's like, whoa, make sure you post. You know, so that's how anxiety works, it's a trigger. What I like to use a lot is the metaphor of a fireplace with people. Like, I mean, anybody have like an old fireplace, like their house, a wooden one, like a wood fireplace? Yeah, if you have a metal glass doors, like you can close the glass doors and the fire goes. So like I would always like watch TV and the fire would be blazing and it'd be 80 degrees in the living room and 60 in the rest of the house. and it was my job to stay up later and watch TV to turn the fire off at night. But if you slide the little grate at the bottom across and shut the glass doors, when there's no air, the fire goes away in about 20 minutes. Doesn't matter how big the fire is. It'll go away in about 20 minutes. And, anxiety works the same way. But here's what we do with anxiety. We get anxious and we're like, he didn't answer his text. And so instead of going, that's anxiety, and I'm not going to worry about that right now. I'm going to focus on what's being said in class. That's not what we do. What do we pull up? Find friends. We pull up find friends. All right, we're at this location right now. I need to know. So we begin to explore the anxiety, and we're like, let me find out what's really going on here and stuff. You know, maybe he posted on Instagram. What did he post? Where is that background? That looks like someplace I have not been. And it's like you start looking at everything, and you're like, now you're exploring your anxiety, and that's like a cloud. It's like looking through a cloud. You're not going to find anything. There's nothing there, and it gets bigger and bigger, and the anxiety gets bigger. See, now you have reason. Now you get data supporting your. Because like, see, he didn't do this. He's staying off it. There's nothing on Instagram. He's staying off Instagram for a reason. Checking Snap story. Nothing on Snap. I know he has something to Snap, and he's not doing it. So he's definitely hiding from me now. He's intentionally hiding and stuff. And then so you're like, his location's at his house? No, it's probably not. He left his phone there on purpose. So now we're just exploring. We're creating a narrative from our anxiety that's completely fictitious. Because when we're hyper vigilant and we're elevated, we don't feel as vulnerable. We're ready for it. We're ready to hear those words of what's going on. And so the problem is, though, we have this anxiety keeping us away. So we depend on anxiety to stay alert. And we feel like we're less vulnerable to threats when we're anxious. And so that's the way the brain kind of works. It's constantly trying to keep that. So when you do come to a place of relaxation, you'll often be robbed of it by anxiety coming back because you feel like you're safer doing that. So we want to do the opposite. We don't want to explore anxiety. We want to recognize it. We train our clients, recognize this is anxiety. This is not real. This is anxiety. Doesn't mean it's going to happen. It's not predictive. Doesn't make you safer. It's just a feeling. And then you take that anxiety and you extinguish it by intentionally placing your brain on facts. You can say, you know what, even if he was doing something, I'll be fine. I'll be okay. He's human. Probably, he has a lot of reasons. There's many good reasons he's probably not answering his text right now. Like maybe his phone's not with him. Maybe it is, maybe it isn't, maybe he didn't get it, maybe he doesn't have service. I'll find out later and we'll discuss it and go through whatever's going on. But I'm not gonna, but you don't have to pursue these rabbit trails of the anxiety. The more you explore anxiety, the bigger it gets and the harder it is to control. So that's what people naturally do with anxiety. They try to disprove it. They try to find out, so you're trying, you get up and you open your computer and you're checking Blackboard, because of the anxiety, and that's fine. It's okay to have a feeling and check it and explore it like that, where something valid could be, maybe you did miss a post. But generally, a lot of this anxiety people experience are just a hypervigilance, especially like generalized anxiety. They feel safer with anxiety. It is like a cushion around them of be ready any minute, just be ready because it could happen. And so people who've been through trauma, people who've been through these things, they have that heightened sense of anxiety. Which is why you see some of the OCD stuff popping up under anxiety disorders. All this obsessive compulsive. Because people who are obsessive compulsive, they're trying to control areas of their life. They want to control something because there's other areas they can't control. So you see a lot of different things kind of coming up around anxiety that kind of pop up. So anyways, we'll keep talking about that more too. I just want to give you a general idea. Any questions real quick of just like treatment, anxiety disorders? So again, we're triaging. You're going to look for what is the biggest problem. What is the biggest cause to lack of function? Yeah.
What do you say is the best way to, you said treating anxiety with data is the best, you find is most effective?
Yeah. So here's what I do. I will take most people's anxiety, first of all. Here's two things I'll do. I'll use the metaphor of a bushel basket, 2 bushel baskets, and I'll tell them, look, let's focus on what you can control right now. This is the biggest thing. So I'll go in, and this is a technique in CBT called circle of control. Mm-hmm. And I'll say, what is within your circle of control? Can you control your behavior, your boyfriend, his behavior? Can you control whether he's cheating right now? No. Can you control whether he answers his phone right now? No. What can you control? You can control your reaction. You can control the level of vulnerability you give to that person until you trust them more. What can you control? So I have them explore that. So you're going to find a lot of people, what they do is they give their locus of control, they put their well-being, who they are as a person, their stability, in the hands of other people. And they say, so it's very similar to, let's say you were in the Chesapeake Bay on a boat and you spent the night. And you're anchored and you're sitting there and you just go to sleep and the boat's just rocking. You get up in the morning and the sun is rising and the birds are just chirping, whatever they're doing, and they're like flying around, and you smell the salt water and you're like, this is amazing. What an amazing morning on the water. But then let's say in the morning you get up and the wind shifts, the boat starts rocking, you get woke up by the boat shaking, and it's windy and it's raining. You get up and you're like, I'm gonna die. Like I could die any minute. Like, it's the same boat. The difference is the weather has shifted to the point where you're feeling a threat of your life right now from the water conditions. And what we tend to do is we take our emotional stability and we anchor it externally in other people and other things. So you're fine tonight coming home as long as your significant other is smiling. Your kids did all the work they're supposed to do and said they would do. And the bills are all paid. There's nothing in the mail that's bad. You're good. But if any of those things are not perfect, you're gonna have your entire set. You're thrown off. You are off. You're unstable. And so, what I do is I take people and I say, okay, let's focus on what you can control. And I say, okay, let's build your own like a wagon wheel. You have spokes that go off to the outside. What are your spokes? Your faith, your relationship with your family, your self-care. What do you do for yourself? Physical health, nutrition, your intellectual pursuits. You can control that. Some of you don't deal with some of the emotional stuff going on in your life right now because you intentionally put your focus into your academics. And you spend time working on it. And you make progress. And you're happy with the direction of your life. Because there's other areas of your life you don't like the direction of that you can't control. And that's okay. You have that thing. But you just have to realize, yeah, those are things I will deal with. Those are things I struggle. But when you take the power you have and you put it into what you can control, you can steer your life in the direction you want it to go and not be, and even though the wind's blowing and the waves are kicking up, you're okay. You're like, you know what? I'm okay. Because I'm going to this will be okay. That'll be okay. This is good. Because you're controlling the areas of life you can control. And then you let go of the things you can't control. At some point, you have to let go of the fact that you may have a brain tumor. Now the odds are you don't. For my client, really good odds. Odds are better than I do than she does, because I don't have a scan of my brain that shows I don't have a brain tumor. She actually has a picture of her brain that says she does not have one. So she is less likely to have one than I am even having one. And so that's the reality of what's kind of going on. And so kind of looking at that data is good. But when you can look at your life and go, I'm okay. Because whether I'm around somebody who's off right now or not off right now, I'm going to be fine. Here's where it gets complicated. when you personally get this down, is brain regulation theory in itself. So let's say those doors were not glass and I shut them, and you have a baby, and the baby was on the outside of the door, and you were on the inside of the door. And the baby couldn't see you, smell you, hear you in any way. When you would come close to the door, and the baby's close to the door, the brain waves and everything within the baby begins to adjust and calm because the baby knows they're close to their mother. The baby's brain electronically is sensing your brain and is able to connect and knows it's connecting to mom's brain with no other input whatsoever that mom's there. And what you're going to find is this, is that we know that people with regulated brains like we have, because we're going to be professionals at sitting in pain and talking to people, we'll have a very regulated brain. People who are dysregulated will be drawn to you because you will regulate them. You can be in the presence of somebody who is just off, and they can become better just by being with you because your brain is regulated. Now, if you get, let's say you're a therapist and someone comes in, oh my gosh, the worst thing happened, the worst thing happened. You're like, oh my gosh, I can't believe that happened. That is the worst thing I've ever heard. Oh my gosh, we're in bad shape. We're both in bad shape. You should do something like this. You're dysregulated, they're dysregulated. They're like chaotic. They run out of there crying worse than you are. You run out of there crying, that's not a good thing. So, but if they come in and you're very regulated, your empathy, your empathic responses, and you are regulated, they will calm themselves just being in your presence. And so just understanding that, you're going to be drawn to that. You may be around those people. People around you will be like, go talk to her. I like to talk to you when I feel off. Yeah, because you have that way of calming them down. That's the way you regulated your brain that way. So we don't want you to be like that, though. We don't want you to be like, I got to get around somebody calm so I feel better. Like, because you're a therapist, right? You're going to be a therapist. So, that's not good. You picked the absolute worst career for that. So, because you intentionally are going to put yourself around dysregulated people on purpose. And so, what you want to do, though, is get to that place where you understand, I'm okay anyways because of this, and this. And even though my bank account says this, I'm going to be okay. My bank account said that before, and I've been fine. And I'm working this to make that better. So I'm going to put myself in a good position. I'm moving in the right direction right now, even though I'm not where I want to be. That's a reframe of the entire same situation. And you're taking your strengths, you're taking what you're doing to make progress that you can control, and you're saying, I'm going to put myself in a better position, even though I'm not there yet. And so all of those things you can kind of do, you can start moving yourself, but you want to focus on the circle of control. So you don't want people to focus on their anxiety. They can't control that because it's not real. The stuff there is not, the fear is, the feeling is, but the data is not. So what can you actually control? Well, you can make sure when you go for a walk, you're nice and safe. If you feel better carrying dog spray, you carry dog spray. But you don't need to worry about that. Because you've walked, how many years have you been walking? You've been walking for 40 years of your life. How many dogs have bit you? 1? When you were what? How old? How many years has that been? 34 more years you've been walking around. 34 years you've walked around cities. 34 years. No dog has ever bit you again. There's a really good chance you're going to walk around another 34 years not have a dog bite you. Do you want to be worried every time you see a dog because that might happen? So that's where you want to kind of go with that. And then hopefully they'll go volunteer at a shelter, and then you'll be like, yay, I won. That's not true. Just saying. But you want people to realize that because they have that narrative in their head that they think is keeping them safe, because they think hypervigilance keeps them safe, they're not actually safer and they're not actually engaged in a threat because of that. They need to focus on what they can control. And they can't control meeting a little white dog. They can control their reaction, and they can control how they handle the thought they get in their brain. You know, they get the dog, oh, little white dog. They might say, oh, you know what? That might be the mean one. That might be a really nice one. I don't know. Either way, I'm across the street just because I don't want to be around little white dogs. But it's all good. I'm still going on my walk. You know, and it doesn't affect them at all. And that's where they kind of get to be. You know, where down the road they may be, you didn't answer his texts. But you're not freaking out over it. You're kind of like, well, you know, sometimes people don't answer a text. Sometimes it's for bad reasons. Sometimes it's for normal reasons. Sometimes I don't answer my texts. You know, sometimes I'm busy thinking about something else. I should probably check my phone right now. You know? I mean, you just totally put your mind on what you can control, and you can help alleviate that anxiety. You don't have to take the bait. Don't get on the roller coaster. You do not have to ride all the rides in the park. All right? Like, don't. A lot of rides in the park. Don't get on them all. You can get on one if you want to. They're not all fun. So I tell my clients that. I had a client tell me that the other day. They're crying. They were like, I just said to myself, don't ride all the rides in the park. All right, that's good. Yeah, so I had a kid come in once. I used to teach a metaphor for ADHD of a remote control. Like, I actually bring remote controls in sometimes. Because every kid knows what remote control is. I don't care where you're from. You're like, you know, you want to work this? Yup. Okay, so I'm like, all right, so let's say you're going to do something stupid, right? What's the first thing you do? What's the first thing we should do now? Instead of just doing whatever comes to your mind. I should throw this chair across the room. Okay, whoa. First thing we do, we want to throw a chair. What do? We only use one button. We only use one button right now. Next week we'll work on another button. This week we'll work on one button. That button is the pause button. Hit the pause button. You hit the pause button. Okay, you got it? You hit the pause button. And then next button, down we teach them later. Okay, you hit the pause, you just pause. Then what I want you to do is I want you to fast forward to what you were going to do and say, okay, throw the chair. What's going to happen? You throw the chair, everyone's going to laugh, the teacher's going to get mad, you're going to go to the principal, you're going to get suspended. You're going to go home and tell your mom you threw a chair. Is that what you want? No, that's not good. Okay, let's rewind. Okay, let's go back. What's something else you can do? I could just go sit down and focus on my work and do whatever. Okay, what happens if you do that? Fast forward. Oh, nothing. I'll just go get through the rest of the day, do whatever, go home, you'll probably get a better grade. Okay, good. What decisions do you want to make? Let's do that one. Okay, hit play. Then you hit play again. So the trick is getting the pause. If you get in the pause, you can get them to change this stuff. But I had a kid come in and he was like, Dr. Holland, I don't know how I got in so much trouble. I hit the pause button. I kept hitting the pause button. I hit the pause button. Nothing happened. I was like, pause button broke. It's not good. I gotta go back. I gotta read a book on something else. I don't know what to do.
Forgot to change the batteries.
Change the batteries in the remote. Change the channel. Yeah, but I mean, it was neat that he actually used the metaphor to say, look, I actually tried to use that technique and just didn't work. You know? Yeah.
I have a quick question. I'll see if I can word this correctly. If somebody is hypervigilant and they are ready for whatever is coming,
yeah,
whether it's a boyfriend, an argument, or whatever, and it happens, so they can never be in a state of vulnerability because every time that happens to them, you know, it's like they're taking 5 steps back.
Mm-hmm.
So what do you say to somebody? It's hard to tell them to me to not think about what's going to happen because it may not. Because every time that person or that time happens, so they're kind of stuck.
And I warned them at that point. Now, first of all, I make sure they're not elevated. If they're like elevated and they're angry, I'm just going to use empathy. I'm going to be empathic and say it's got to be really difficult. You keep running into guys who don't answer texts and then they have girlfriends. It's your 6 to 1. It's really rare. But I mean, it's got to be tough for you, you know. And then say, okay, well, you know, the hard part's going to be is down the road there's going to be somebody who doesn't do that, you know. And maybe you need to look at where you're choosing your friends from. I had a girl from Virginia Wesleyan. She was just like, I don't understand it. I just don't understand it. Guys are just jerks. I mean, one was a jerk. Well, they may call him, I don't know. But one of them was like legit, and we all agree. he's in the car and she's like, I'm really having a hard time with my anxiety. He slams on the brakes and says, get out of the car. I can't have that kind of drama in my car. Kicks her out of the car on the side of a street and drives off. Okay, so like, he's the winner. Like, that's the winner. I gotta drop the mic on that. Yeah, you win, man.
Okay.
Worst boyfriend ever. There you are. But she's like, I don't know. These guys are just they're just jerks. I don't understand. I met one, he said he was just different. And he actually waited before he wanted anything physical. And he was just really nice. And then she's like, I don't know. I said, well, where are you meeting these guys? She goes, the last 5 I met on Tinder. But I don't think, I'm like, well, you're fishing the wrong pond. That's the pond you're going to get. Like, I mean,
Yeah.
I'm like, how many times do you keep fishing in that pond to get the same kind of fish? And you're like, expect some different results. So sometimes you have to challenge, okay, well, let's look at the patterns here. What else is going on? But then when you're dealing with the anxiety itself and the fear, you got to realize the hypervigilance does not keep you safer. What's going to keep you safer is knowing you're okay no matter what. You're okay if they're not what they say they are. You're going to be okay. Because your well-being doesn't depend on other people's behavior. I don't care how good of a person they are, how much they love you, you don't put that weight on somebody else. Ever. I would put that on my wife, and I think she would love me to the absolute end of the moon and back. But I'm not going to put that weight on her to say, look, my well-being depends on her, every decision she makes being perfect. It's too much weight. So you challenge that, but you redirect them back to controlling what they can control. Good question.